Good morning, everyone. Hi, thank you. My name is Jennifer Pells. I'm a clinical psychologist at a residential obesity treatment center in Durham, North Carolina, which is about 6 hours north of Atlanta. So I really appreciate the opportunity to be here today. I'm loving this international perspective. So many of the conferences I attend are just in the States. So I think that's really adding something important. So I'm going to take a little departure from some of the intense basic science research that's been presented and discussed. Since I'm working in an applied clinical setting and I'm a behaviorist, I hope these guys will forgive me for not presenting basic science. But I am going to review some data population. Specifically, I'm going to be focusing on issues of weight maintenance. And I know there was a talk by Dr. Leibel yesterday on weight maintenance following bariatric surgery. I'm going to be looking at weight maintenance in behavioral obesity treatment. And I really want to frame this talk from that perspective of weight maintenance because it is such a critical issue in obesity care. So a lot of times we think about the issues of initiating weight loss and getting people into treatment and helping people make initial lifestyle changes. But what can get lost and has gotten lost in some of our research efforts is the ongoing need for care, the ongoing need for weight maintenance. It's a significant struggle, and weight regain is the norm following initial weight reduction. So I'm going to frame the talk that way. I am going to describe some of the preliminary results we have from some efforts we've made in our program to address weight maintenance in our population, and show you some preliminary results from that data. Well, what I'm going to present today is descriptive data as opposed to inferential, statistically analyzed data. I do hope that it'll maybe encourage some curiosity in thinking about this dilemma of weight maintenance for folks who are losing weight, and maybe think about some directions going forward I think ultimately this is going to require creative, empirically driven, patient-tailored ways, probably using technological interventions to really come up with unique and innovative models for weight maintenance, because unfortunately, as a field of obesity providers and researchers, we just haven't done that well so far with weight maintenance. I'd like to spend a moment looking at what some of the challenges are related to keeping weight off. I think sometimes some of that can get lost. We can have maybe a cavalier attitude. Well, once somebody's lost it, they should just be able to do the same things to keep their weight off, or they should have it. When really this is actually as complex as the development of obesity itself, the issues of weight maintenance, and it's a host of environmental, biological, and behavioral processes that can promote regain after weight loss. And it's really important to understand that that's what individuals are facing as they work to keep their weight off. So the first point is around sustaining the necessary behavior changes. There's a lot of work that goes into lifestyle-based behavioral weight management. There's a lot of burden on an individual on any given day to be consistent with those health behaviors, particularly in environments that are promoting us toward overconsumption, toward sedentary behavior. So we might initially think that it would be harder to lose weight than maintain weight loss, because when you're initiating weight loss, you have to adopt several new behaviors. There's high demands on time and effort. It might be difficult to start to exercise because of physical conditions, medical conditions, because of excess weight, mobility limitations. So true, there are certainly a number of challenges in initiating weight loss. But on the other hand, there's several reasons that it might even be more difficult to maintain that weight loss. Successful maintenance requires ongoing consistency with the health behaviors that helped you initiate weight loss. And too many of us still have an attitude that will approach weight loss, we'll work to weight loss, and then we'll sort of level out and then be able to sort of just coast or maintain. When the reality is it's not a model that looks like that. The reality is weight maintenance is a very dynamic process. Many of the behaviors used to lose weight are the same exact behaviors that need to continue forever. So weight maintenance has its own set of challenges. So one concept that's spoken about often in this literature is that of behavioral fatigue, that recognized phenomenon of of becoming fatigued by all of those behavioral efforts and having subsequent lapses in health behavior because of that. It's difficult to maintain the dietary restraint that's needed to keep your lost weight off on a day-to-day basis, to keep prioritizing exercise over other demands. So behavioral fatigue is a very real construct in this literature, and understanding that that's what individuals are dealing with is really important. We think about the rewards that come with initial weight loss. So when somebody embarks upon weight loss and starts to see that success, sometimes the novelty of the behaviors, humans like novelty, so sometimes the novelty of the behaviors keep us motivated for a while. The compliments are positively reinforcing. The sense of feeling better physically, emotionally. Reductions in medications may be rewarding. Seeing that number decrease on the scale. All of these are aspects of why weight loss has some rewarding, reinforcing properties. When you get into weight maintenance, trying to keep off lost weight, not necessarily losing more, or maybe trying to continue to lose more, that novelty wears off. The compliments stop coming. The medications may already have been reduced. You're already feeling better walking. So the number and intensity of reinforcers to keep the behaviors going can diminish. And we know from behavioral psychology that when reinforcers diminish, behaviors weaken. So there's a very real loss of reinforcement value that happens through weight maintenance as well. Physiologically, and this is perhaps where some of the most interesting promoters of weight regain live, I think, there are a lot of physiological adaptations that occur when one has reduced their body weight. So the demand for energy is reduced, right, to support a lower body weight. So the rate of resting metabolic rate decreases as weight decreases. That means fewer calories are needed to maintain that weight. So one is faced with maintaining a level of dietary restriction and restraint, perhaps even needing to eat less over time in order to keep that weight off as that physiological metabolic adaptation has occurred. There are hormonal adaptations, alterations in ghrelin and leptin levels that we now know occur with weight loss through reduced body weight. At the very same time that you want individuals to stabilize those hunger and fullness hormonal cues, weight loss seems to promote the opposite. Ghrelin levels increase, right, creating greater sense of hunger. Leptin levels decrease, creating greater loss of satiety. So translates to we feel hungrier and less full when we do eat, right? Obviously, this isn't going to promote weight maintenance. It's going to promote regain through increased consumption. So a number of physiological processes are occurring that are very real promoters of weight regain in folks trying to maintain their loss. And of course, we can't ignore that one who's trying to lose and then maintain their weight loss is probably doing so in an obesogenic environment, right? No matter what country or culture we might be living in, we know there are any number of cultural norms, pressures, expectations that promote sedentary behavior and overconsumption, right, on a day-to-day basis. So trying to navigate what one has figured out works for them in terms of healthy behavior change is going to be pulled at all the time from those cultural forces that have contributed to obesity on a large scale. So constantly trying to do this in an obesogenic environment is incredibly challenging. Number of factors, this is a quick overview, obviously, of the challenge of weight maintenance, but a number of factors that lead to regain. In the behavioral weight loss field, I'll just put all of these up. In the behavioral weight loss field, when maintenance has been studied and researched and evaluated, and to some extent that research is lacking, but we have some typical information about behavioral weight loss programs that show us why weight maintenance is so important in treatment efforts. What we know is that most adults completing any kind of standard behavioral weight management program in the U.S., it's very common for those to be hospital-based, to be maybe 12-week or 24-week programs, behavioral weight principles taught in a group setting. Very common when somebody completes a weight management program like that to lose between 5 and 10% of their body weight, which is a great start and leads to some really important health improvements. What we know also is that most will regain about a third of that lost weight by 1 year's time following their treatment intervention. So already in that first year, regain is occurring, about 33% of what they lost. What we also know, even more unfortunately, is that within 3 to 5 years following that treatment intervention, most will return to their baseline weight, right? And then we have that yo-yo effect, up and down, up and down. Those who are successful, right, and it does occur, those who are successful at maintaining their initial weight loss tend to use a high degree of behavioral strategies on a day-to-day basis to keep that weight off. So they're never, those who are most successful are reporting that they're never getting to sort of a complacent point where they feel like they've got it, they've done it, and they don't really have to continue. Instead, they're reporting a high degree of vigilance around their food intake, especially low-fat eating, a high degree of vigilance around their exercise behavior. If anything, their minutes of exercise increase over the weeks and months of their maintenance, a high degree of self-monitoring, recording their eating and their exercise behaviors, tracking their weight on a daily basis. There's a lot of work that's going into it for those who are successful. And the good news, and I'll reiterate this again at the end, is that we know from studies that those who have been able to maintain anywhere between 2 and 5 years following their initial loss, they greatly increase their likelihood of being able to do that for the long term. So there seems to be some sense if you can get through an initial challenging curve of 2 to 5 years of doing this work, that the habits become more solidified, truly more lifestyle-based, and the sense of effort. The behaviors don't decrease, but the sense of effort and the likelihood of keeping that weight off greatly increases. So this is a little bit about what we know, right, in terms of the field. This has led to several efforts, many in the U.S. starting in the mid-1980s and continuing to look at better ways to enhance behavioral weight loss with maintenance therapy, with maintenance contact. Usually that means some kind of ongoing clinical contact following the initial weight loss program. This is just one example taken from a gentleman at University of Florida, Michael Perry, who's done a lot of work in maintenance work with weight loss. This is very typical, showing that everybody received weekly treatment for about 24 weeks, and then they broke them off into 2 groups, and then they started either no additional contact or bi-weekly maintenance therapy, usually by phone. And we start to see what happens. That top line is the group who just received the initial treatment and no maintenance work, and the bottom line is those who went on to receive an additional 24 weeks or so of biweekly maintenance therapy. And those lines, of course, begin to deviate, where regain starts almost immediately for the folks who had no additional contact, and that regain did not start to occur until the end of the maintenance period for those who had that additional contact. So we have to note here, this is why we're not perfect at this yet, is that regain did recur. It was delayed, and it wasn't as intense in magnitude. And of course, it started to recur once the additional contact was over. I show you this today. This isn't my data, but this is a very common pattern when we look at what happens with weight maintenance trials. That again, once that contact ends, there's additional regain. So let me turn now a little bit to the current study, the evaluation of some of our data at Structure House that I did. I wanted to evaluate our version of some maintenance therapy after initial treatment, and that occurs in the form of return visits, or what I'm calling booster visits. So folks who come to us initially often stay for, our average length of stay is 28 days, residentially based, weight management focus, and a return visit is one way that they can re-engage, that they can maintain some maintenance contact, some additional therapy. So I wanted to look at the pattern of return visits, kind of how were people utilizing those. Those are done at will, self-referred, initial treatment and continuing treatment. So I wanted to look at how individuals were using those return visits, whether those return visits were associated with their ongoing weight loss success, and then begin to compare what happened for returnees versus non-returnees, those who didn't return after their initial visit. So while it's a little bit harder to capture that data because non-returns didn't return, right, we do have 12 and 24-month standardized follow-ups. So we are able to get some data at 12 and 24 months from folks who didn't return to the actual facility but kept in contact with us. It's a smaller subset of data, but I'll present some of that so that we can at least begin to do that comparison of what impact did this form of additional treatment contact have. So let me say a couple of words about the initial intervention that's used. Residentially based means that individuals do come away from their lives to our program. They reside in condo-style private apartments on our campus, usually about 4 weeks, although the length of stay does vary greatly. The treatment facilities are within easy walking distance, and everything is provided on site, so you sort of think of this as like all-inclusive. We go on all-inclusive vacations. This is not a vacation, but it is all-inclusive. All meals are prepared and provided on site in close collaboration with a registered dietitian. The exercise facilities are on site with exercise physiologists and trainers, and there are a number of psychoeducational classes and psychotherapeutic activities, including support groups, individual psychotherapy. So it's a multidisciplinary program. The emphasis, the theoretical orientation, is behavioral and cognitive behavioral. We focus a lot on psychology of eating and weight and behavior change, as opposed to just focusing on the number on the scale. So there's a lot of discussion and work and skills training around, for example, coping with stress in ways that don't involve food, socializing in ways that are less likely to involve food, understanding each individual's relationship with food or their attachment, how they might be misusing food in their lives. So that's the sort of psychological behavioral emphasis that we have. We do view obesity as a chronic disease with a lifelong course. That's why maintenance work may be very important. We try very hard to re-educate folks who may be coming in believing that it'll be 4 weeks and they're done. So we educate and re-educate a lot that it's not one and done, that no matter how you might re-engage treatment, that it's probably a lifelong self-management illness like many others. We focus on following empirically supported guidelines in nutrition and fitness and in the behavioral components. So, for example, most folks are put on a hypocaloric diet of about 1,200 to 1,600. It's not a very low calorie diet. It's moderate restriction, and it follows American Dietetic Association guidelines. Folks are self-referred. They can look at a website and enroll in the program on their own. Often physicians or family members may also refer, and it is self-pay. And like I said before, the average length of stay is 28 days. So that's our initial intervention. This is not data from the sample I'll show you today, but it is typical 4-week results in terms of health changes, just so you get a sense of what happens in 4 weeks for these folks. The average body weight loss is about 5.5% from where they started at that initial 4-week treatment. And there's a host of lipid and cardiovascular risk factor markers that we assess, and we do see significant reductions over the 4-week period, probably largely determined by the diet that they're following when they're there. We also measure psychosocial changes, including depressed mood and quality of life, and we see improvements in 4 weeks' time. So looking at the sample that I did analyze to look at our return visit data, I selected 981 cases from individuals who started treatment between 2008 and 2013. You can see the breakdown demographically. We are primarily Caucasian, majority female, average age 50 years old, and our average BMI is 42, so this is a more morbidly obese sample. If you look at the breakdown for return visits versus not, among those 980 or so individuals, 274 did have a return visit in that time period. The remainder, 700 or so, did not. And we looked at evaluating those outcomes both at the time of the return visit, which would have been an objectively measured on a scale at our program. So if it's a return visit that we're analyzing, it was an objectively collected follow-up weight. If it was, some of the data I'll present to you is at 12 and 24 months. If it's at those standard follow-ups, that is a self-reported weight, because that's coming from the web for those who didn't come back to the program. And I just gave you on the right side, I just gave you the overall weight trend, not distinguishing returners versus non-returners, just looking at that entire 980 sample. What was their overall weight loss trajectory from pre to post-treatment to 6-month follow-up, 12-month, and 24-month. And you can sort of see this nice line of gradual weight loss. The most, of course, is occurring in that initial treatment phase when they're in the most controlled setting. And we're handling the food for them. And that weight loss slows down as folks go back into their home lives after treatment. But we do see that they're able to continue losing. And that slight amount of regain doesn't begin to occur for this sample until somewhere between 1 and 2 years, and it was very slight, which is promising. If we look at simply the number of return visits, that number 274 that had a return visit corresponds to 28% of that sample. So a little over a quarter made at least one return visit during that 5-year period that was analyzed. The remainder, 72%, did not have a return visit. And that bottom circle, among those 28 who returned, this breaks it down into how many return visits they had. So you can see that the overwhelming majority, 188 of them, had just one return visit in the time period analyzed, and that smaller section had multiple return visits, 2, 3, 4, 5. When they do come back for return visits, there aren't strong distinctions between initial folks enrolled in the initial treatment program and those coming back for a return. The idea really is like a booster visit. So there may be, there are some classes and activities that are geared toward the experience of those who've been to treatment before, who are doing the work at home, but by and large, it's the same types of classes, it's the same clinical activities, it's a chance to refresh, to be supported, to reinforce some of the things they've been doing, to anticipate challenges going forward. It's really more of a reinforcement model than a whole new treatment paradigm. It's very similar treatment when they come back. The field of behavioral weight loss doesn't change that rapidly. The skills are the same. And a return visit does allow somebody to individualize their treatment a bit more. It's a fairly prescribed, structured program when they come initially. Return visits allow more flexibility for individualization. Some folks might want to spend more time doing the therapy-related activities. Some might want to spend more time in physical activity, for example. So if we just look at return visit patterns, both of these tables refer to just those folks who had at least one return visit. And this was just a snapshot of when they were selecting to have those visits, which probably says something about when they were feeling the need to have that return visit. From initial visit departure to that first return visit, it was about a year, about 11 months time passed before they opted to come back in and do a return visit. And that time frame got slightly smaller when you look at multiple visits, first return to second return, et cetera. It ends up being about a 9-month window at each of those times. And duration of return visits, how long are people staying when they come for return visits, because again, this is self-selected, self-determined. Beyond that initial month, the stay gets shorter with subsequent visits, about 3 weeks for the next visit, and then stabling off around a 2-week return visit. And some of that is guided by the admissions directors and the admissions staff when people ask what makes sense in terms of return visit. A booster visit can often be very effective in 1 or 2 weeks. I did look at whether there was a correlation between just absolute number of return visits in that time period and weight loss outcomes, and to somewhat my surprise, there was not. It does not seem to be the number of returns that's dictating or influencing, but the pattern of return visits, the timing of return visits did seem more important. So the table below shows the lag time, the return time frame, 0 to 3 months, 3 to 6 months, from initial visit to next visit. Right, so just that first return visit captured here. When did they come back? And you can see, and I've highlighted a bit here, the percent weight loss from that starting weight was greatest if they came back within that 12-month. So 3 to 6 months, 6 to 9 months, 9 to 12 months. When you get outside of that 12-month window, right, we're seeing some diminishing return. We're seeing some smaller weight losses. So this is very interesting when we think about maintenance protocols, maintenance programs. When is the best time? What is the best way to support people in maintaining their weight loss? There is starting to emerge a picture here where self-selecting, they're often choosing to come back within 1 year, and their outcomes are being supported by that choice, right, to come back within a year's time. Going beyond that, my speculation here is that going beyond that, we might be seeing folks who are more reactive. Perhaps they're already starting to regain, and they're reacting to that by coming to treatment. Those who come in the first 12 months, one of those 3 kind of critical breakdown periods, they maybe have a more proactive mindset about this work, recognizing that it's important to return, have additional treatment of some form before the regain is occurring. So I think there may be a different mindset for them there, and their outcomes are showing that. This is a slide of what occurs between visits, so that sort of critical work of needing to do the work at home outside of treatment. Are the skills generalizing? Is the work generalizing? We do a pretty good job helping folks generalize from their initial visit to until their second visit in terms of being able to sustain their weight loss, to keep losing weight during that initial home time. So that lit up blue part on the left circle shows that 58% of those who had a second return visit were able to continue losing at home, which is where the work is the hardest, right? 38% did show some weight gain. It was not dramatic weight gain, and 4% were able to maintain from first visit to second visit. So we feel pretty positively about that. Then we look at the data from second visit to third visit, so more time is passing. This may be anywhere between 2 and 3 years at this point, where the proportion of folks who are regaining during that time from the last visit to the next visit increases to 74%. So we start to see where that regain is occurring, where that difficulty is occurring. An additional 22% were able to keep losing, 4% maintaining, but we of course are starting to see some more folks struggle. For those who did come back and have a third or fourth visit, when they came into their fourth visit, we analyzed the same data. 68% had gained from that third visit to the fourth visit. Still a pretty high number, still about 2/3 of our sample, but some degree of stabilizing at that point. Probably with those visits, we're starting to see some folks who are getting it, right? And it's starting to click and the behaviors are solidified, but many are still struggling. This tells us, of course, yes, weight maintenance is still a challenge even after intensive residential care. Broke this down by 1 year and 2 year follow-up, and I looked at it by absolute number of no return versus a return visit, at least one return visit. So this is just simply gray bar, no return visit for these folks at 1 year and 2 years. Blue bar, these are folks who had a return visit. And along the left side, the y-axis is the number of participants who fell into various weight loss degrees. So I was looking at whether they regained or maintained, and then if they were losing, which degree of weight were they losing? 0 to 5% of their body weight, 5 to 10%, et cetera, right? So obviously what you want is you want lower numbers on the front side, right? The regainers, maintainers, and 0 to 5% loss. You want lower numbers of individuals in that category, right? Because they're not doing as well. And you want higher numbers of individuals, higher bars, as you move to the right of the graph, right? Showing that we're getting higher weight losses, maintained weight losses. So at 1 year, we're seeing some real differences between those who returned and didn't return, right? The blue bars are higher as we move to the right of that graph, higher levels at 10 to 15% weight loss, at increasing beyond 20% weight loss. This is good news. Those who weren't returning are struggling more by 1 year, higher rates of regain, more likely to be a maintainer than an additional weight loser, and the higher bars are 0 to 5% and 5 to 10% as opposed to greater weight loss percentage. Interesting to look at is what happens at 2 years, right? Same bars, same analysis. Still, those who have not returned at that point are experiencing greater regain, which probably shouldn't surprise us. They haven't had that additional treatment. But there is some evening off where we're not seeing such distinctions between the returns and the non-returns at 2 years. So to some extent at 2 years, whether you had a return visit or not, isn't having as much of an impact on your outcome, which again might mean that as time goes on, some of those folks at home not returning might be starting to get it and have some of those behaviors solidified. Or it might mean that the really critical window is around 1 year for that return visit, and that really starts to make a difference. And then I'll just show it this way. This is by percent body weight reduction. Higher numbers here are good. It means you're losing more of your initial body weight percentage. Not surprisingly, when you're looking at returns and no returns, everybody's doing pretty much the same during their initial visit, about that 5.5%, 6%. That's the first bullet point on the first data point on that slide. You haven't returned yet, so you're doing fine. Then we start to look at that percent body weight from initial visit to 6-month follow-up, and we start to see that divide. The returns are doing better at 6 months' time, some of whom have already had a return visit in that time, and they're continuing to lose their weight. They're continuing to lose at 6 months, they're continuing to lose at 12 months. It's not until 24 months that we see the returners start to slide a bit, right? And still, they're in double-digit percent body weight loss, which is quite good. That's hard to maintain. If we look at what happens for those non-returners over time, they do fine during initial visit. They do continue to be able to lose weight during their first 6 months, and then they pretty much stay steady without that additional treatment. There wasn't significant regain, which is wonderful, but they were staying steady. And given the starting BMI of this group, most were most certainly wanting to lose additional weight. They probably did not consider themselves maintainers at that point. They were holding on to about a 9% weight loss even through 2 years. Okay, let me show you a few of the summary points here. When I look at this data, I conclude that there is some treatment value here. There is a benefit in the form of booster sessions or return visits. That's to enhancing weight loss, sustaining additional loss, maintaining the loss that has occurred, following the residential treatment program. So I think there's some promise in this maintenance model, that it's not a scripted, programmatic, everybody follows the same maintenance model. It's really much more, because of the nature of the treatment setting, it's much more individualized and individual decisions about when to return. And I actually think that might be an important element to look at further. In the literature, most treatment programs are really scripting out ahead of time what their maintenance protocol will be. And as we can see, we historically haven't done that well. So I think that this starts to make us maybe think a little bit more creatively about what maintenance treatment can look like, and that it may not be something that's best prescribed by the time frame that the provider thinks is important, but maybe by the time frame where the individual is really feeling the need for that booster treatment. We are seeing some data point us towards some critical time periods, perhaps 6 months, perhaps 12 months. That 1 year window is really standing out to me. I know, going back to my program after looking at this data, it makes me think about what are we going to most make available and most speak to to our participants about the importance of maybe doing some additional contact by that 1 year point in order to maximize their weight loss. The longer term outcomes, the 12-month, 24-month, the pattern of slower regain that occurs even with additional treatment, very consistent with other studies as well, telling us that there is still a lot further to go in terms of our work in weight maintenance. We do see that intensive initial treatment, because folks, even those who didn't return, were able to still maintain at about 9% of their body weight loss. I think there really is some promise for an initial intense start to their weight loss. But again, it looks like it will be best bolstered by some additional treatment.